Yeah, so we will discuss this paper. The vascular invasion identifies the most aggressive histologic subset of stage 1 lung adenocarcinomas, implications for adjuvant therapy. This study was done in two centers, Boston Medical Center and Leahy Hospital and Medical Center in the United States. So we all know this. The new thing is that there are 5 histological patterns on the basis of which the grading of adenocarcinomas of the lung is done. Lipidic, acinar, papillary, micropapillary, and solid. And this was the basis of the WHO 2015 grading system. Very quickly they realized that even a combination of these histologic patterns also change, and it's not just the predominant histological pattern that is important. So in 2020, it was taken up by IASLC grading system and then was adopted by WHO in 2021. So in this study, the resected stage 1 lung adenocarcinomas measuring less than 4 centimeters total size and not treated with neoadjuvant therapy were identified. And little more than 500 patients were analyzed. The histopathological analysis was done based on WHO 2015 grading as well as WHO 2021 grading. And 2021 grading is, grade 1 is lipidic predominant with less than 20% high risk, high grade patterns. Grade 2 is acinar or papillary predominant with less than 20% high grade. Grade 3 is more than 20% high grade patterns including solid and micropapillary as well. Interestingly, in the last slide it was mentioned. So just as in breast cancer, we have T stage based only on the invasive component of the cancer, not on the DCIS. The tumor may be 4 centimeter size, but if the invasive component is just 0.5 centimeter, the T stage is according to 0.5 centimeter. Similarly, in lung cancer, it was realized that lipidic pattern is non-invasive, and therefore, when we calculate the T size in pathological stage, it is on the non-lipidic component of the lung cancer. Also, low malignant potential adenocarcinoma was found, and that was particularly defined, and these were excluded. The survival assessment was done according to recurrence-free survival, disease-specific survival, and overall survival, the standard definitions of both. The results, as expected, 62% females. The tumor size, if you see, the total size was 1.6 centimeter median with an invasive size of 1.2 centimeter median. Outcome, the recurrence-free survival 7-year was 86%, disease-specific survival was 89%, overall survival 66%. If we analyze according to the stage subgroups and WHO grades, beyond the stage, the grade did not matter in this study. So stage for stage, the grade did not matter for this study. Histologic features, again, if we look at, this is a busy slide, but an important slide. If we look into the recurrence-free survival, disease-specific survival, as well as overall survival, so they have done a univariate as well as multivariate analysis, and in which they found that on multivariate analysis, the grading does not matter in either of these outcomes. If we look into the other things, vascular invasion, lymphatic invasion, and total size more than 3 centimeters, on multivariate analysis, these two matter for recurrence-free survival as well as for disease-specific survival. The only thing which I would not say reached the p-value of less than 0.05, but it was very close to that in multivariate analysis for overall survival was vascular invasion. So vascular invasion is the only thing here which actually mattered. The p-value was 0.06 if you look into that figure. So that alone mattered in multivariate analysis. Interestingly, if you look down, I don't know whether this is working or not. So if you look at this sublobar resection. So if you look here, the sublobar resection had an inferior outcome in this particular study. But that was not the purpose of this study actually. The histologic grouping and survival analysis, as expected, the top one, the blue figure in all these things, recurrence-free survival, disease-specific survival, and overall survival, are actually adenocarcinoma in situ or minimally invasive adenocarcinoma or low malignant potential adenocarcinomas. And quite expectedly, they do better than others. The middle one is actually the other usual adenocarcinomas without vascular invasion. And the lower one is the usual adenocarcinomas with with vascular invasion, which they have called angioinvasive adenocarcinomas. So angioinvasive adenocarcinoma is defined as presence of vascular invasion. It has been long recognized as a prognostic factor. And more recently, it has been included as a prognostic factor in AJCC staging as well. On multivariate analysis, we saw that vascular invasion appears to be a stronger prognostic factor than visceral pleural effusion. Now, visceral pleural effusion changes the stage. But as of now, vascular invasion is not changing the stage. And in this study, the vascular invasion was found to be a worse prognostic predictor than a visceral pleural invasion. So the authors suggest to designate adenocarcinomas with vascular invasion as angioinvasive adenocarcinoma to reflect their unique biological behavior. And it would be analogous to a thyroid cancer in which follicular and Hurther cell carcinoma actually is defined on the basis of capsular or vascular invasion. So adjuvant chemotherapy is currently recommended for larger tumors. The competing risk for mortality has limited its use in smaller tumors. There was some survival advantage for stage 1 to 3 lung cancer for the patient who had vascular invasion, but NCCN guideline does not suggest adjuvant chemotherapy for isolated things. In combination, it may be an indication. We have discussed this. The limitations, it is retrospective. The patients of Asian descent were very limited. It does not compare the prognostic impact of vascular invasion based on arterial versus venous invasion. The histological assessment was based on HNE rather than elastic and immunochemical stains, which can actually overestimate the vascular invasion. The conclusion was angioinvasive adenocarcinomas is the most aggressive histologic subset of stage 1 lung adenocarcinoma, comprising 26% of the cohort, and intensified therapy should be evaluated for this subgroup. Thank you so much.